here presenting. He's an otolaryngologist from Century ENT. And he's going to talk about options for sleep apnea, different treatment options, give a little bit of background. Inspire is one of the treatment options that he's going to talk about. And I work with Inspire with Dr. Amine, and we're super excited to educate everyone and answer questions and learn a little bit more today about sleep apnea.
All right, thank you, everyone. It's okay. Welcome, everyone. A few interesting facts. This is the library I grew up in. I came here many, many times growing up. We grew up in Oak Lawn. I was born in the hospital. I'm one of 7 kids. My father practiced neurosurgery for 40 years in the hospital. So I went into ear, nose, and throat because he was at the brain and I couldn't reach that. I got right underneath in the nose. So my background actually is an ENT, but I spent a year doing a fellowship in sinuses and skull base, but sleep has taken a very interesting turn, and it became part of all ENT practices. We were one of the first to jump on the innovation that has come about in the last 5 years. It's actually been around for longer than that, but has been more mainstream in the last 5 years or so. So that's where we're going to talk about a lot, but we're going to go over some basics as well. So sleep apnea is defined as cessation of sleep. Primarily, obstructive sleep apnea is something causing blockage of the airway within the throat. So the tongue and the soft palate relax, all the muscles relax when you go to sleep. So there's some obstruction, your oxygen levels can go down, and this can cause a lot of stress reaction because when your oxygen levels go down, your heart starts racing, cortisol or steroids gets secreted in your body. This is a sympathetic response. Your blood pressure goes up, your heart rate goes up, and this can cause you the risk of things like hypertension, strokes, heart attacks, and things like that because of the activation of this sympathetic system. On a sleep study, which is what you use to diagnose sleep apnea, you'll see these drops in oxygen, and they also measure the flow of air when you're breathing or not breathing. So these are the things that are measured. There's prevalence means how many of the total population has something. So about 5% of women and 14% of men have sleep apnea. And if you take that across the world, that's about 1 billion people who have sleep apnea. And it's a good percentage. It's about 1/6 of the world's population. And it's very closely related to our weight. So this is something that's becoming worse over time with our obesity epidemic. So it's really important to understand that there are more than just, commonly people with sleep apnea will have symptoms. Things like fatigue, sleepiness. Snoring is a sign of sleep apnea. A lot of people will come and they say, I snore, I have sleep apnea, but that's not necessarily true. There can be people who snore, they don't have sleep apnea, but a lot of people who do have sleep apnea actually do snore. If you think about it, snoring is the vibration of tissues in the throat or in the airway. So if you have those tissues that are close together because of narrowness, you're more likely to snore. So, but that's not always the case. So like we talked about, there are symptoms like snoring and fatigue and diminished productivity due to decreased concentration, but there's also health side of risks as well. Especially important is your heart and your brain, so risks of heart attacks and strokes. And that's just, this is just kind of a short list of it. It includes things like even diabetes because of that steroid level goes up at night because of the stress response. So the first line treatment for anybody who is diagnosed with sleep apnea is typically after weight loss, it's CPAP. So what is CPAP? Anybody here on CPAP? A lot of people. I'm sure you guys all love it. That's why you're here. So CPAP, what does it do? It stands for continuous positive airway pressure. So what is it actually doing? If you think about it, that collapsible airway needs to be opened up. And so the pressure of air actually does that. It stents it open. Well, that can create problems, right? Leaky masks, air going down into your esophagus, you know, there's a lot of issues with it. But if you can use it successfully, it's very effective. And so that's why it's considered first-line treatment for people with sleep apnea. However, there are a significant portion of people who don't end up using it, and it's quoted at usually 50%. Some studies quote it up to 70% of patients don't end up using it long-term. Like I said, if you're using it, you're like these people on the left, smiling while you're sleeping. But on the right side is a lot of people's frustration, and they look for alternatives. So just to be complete, there are other therapies that you can use that are non-surgical, including obviously weight loss. The medications that you see or you hear about, the weight loss medications, are very popular. You know, this is an important part of management of people's sleep apnea is weight loss. Oral appliances. Has anyone heard of an oral appliance?
Yeah.
Yeah. So essentially what it is, it's the same idea as trying to open up the airway, but it does it by pulling the jaw forward. So it hooks onto the top and bottom teeth, and then there's a crank and it pulls the jaw forward, pulling all the tissue forward. So it kind of opens up that airway. So some people can use that and do it successfully. However, some others can create jaw problems and pain and malalignment. So there's a place for it, but not everyone can do it. And then finally, positional therapy. These are for people who are back sleepers and they have this collapse when they're on their back, like they can't sleep in any other position. Or on their sleep study, it's measured that most of their apneas, most of their obstructions are when they're on their back. And if you think about it, the tongue and the tissues fall back and cause obstruction. So if you turn somebody over, maybe you know your partner is, when they're snoring, you push them to their side and they're not snoring as much. So this is something where basically you can buy these off of Amazon. They're like a belt or harness, and you just wear it, and it's got a bump on the back, so it just prevents you from laying on your back. So moving on from non-surgical to surgical. So there have been a lot of different surgeries in the past that have been trying to address this problem, and all of them pretty much fall within ENT, okay? The issue is you have to identify the site of obstruction, okay? Here's a picture of the flow of air that's going from the nose or the mouth. And so anywhere along this pathway, you can have obstruction. So in the past, people have tried to fix the nose to try to help with sleep apnea. People have had their tonsils removed. Some people have their palates resected. Some people have had part of their tongue removed, this back part called the base of tongue. So a word about these is that they all try to find that area of obstruction and try to address it. The most common surgery that used to be done in the past, let's say 10 years ago and before, was called the UPPP or uvular palatoplasty. That's where you actually remove the tonsils, the palate, and the uvula, and you end up with a picture like this, where it's kind of opened up. However, this has, first of all, it's a pretty hard surgery to recover from. If anyone has ever seen or heard of an adult having their tonsils out, this is that plus, because you're removing the palate with it. And the success rate of it is about 40%. So in general, this has gone away. Is that my phone or somebody else? No. Okay. So this UPPP has had very limited success. I'll probably do it maybe once a year these days, only if I have a very select patient has these very large tonsils or this very long palate and is kind of in the skinny profile. So these are patients that you kind of pick very, hand select these patients, and you know these patients have most of their obstruction in this area. And these are the patients that will do well. But again, the surgery itself, it's not that hard to do, it's that the recovery from it is pretty horrendous. Nasal surgery, you'll hear this. In my opinion, this is not going to treat your sleep apnea, and actually the literature supports that. It's not going to treat sleep apnea, even despite what you may hear on the commercials. Fixing the nose isn't going to fix sleep apnea, because if you're not breathing through your nose, by default, you're going to be breathing through your mouth. Now, it may help with snoring, but again, you're not addressing sleep apnea, because as we'll talk about in a little bit, most sleep apnea problems come from the back of the tongue and that area around it. Okay. When do I offer this surgery? For patients with nasal obstruction, for patients who can't breathe out of their nose at night, who wake up with a dry mouth, for somebody who's trying to use CPAP and feels like there's too much pressure in their nose. This is a pretty simple surgery. It's probably one of the most common surgeries I do, but it's not ever for sleep apnea. It's more for nasal obstruction. Please feel free to raise your hand at any time and ask some questions. So this brings me to upper area stimulation. So this is where Inspire came in first to the market for this area, where the airway, if you think about it, the tongue is a muscle. And when you do sleep, what happens to all your muscles? They relax. So because it's such a mobile muscle, it's a pretty large muscle, it relaxes and falls back and causes obstruction. And so the problem is dynamic. And so what the upper airway stimulation aims to do is to stimulate that muscle so that it can contract and widen that airway. So basically is moving the tongue so that it's not so floppy anymore. So this has been around since 2014, right? But it's been FDA approved since 2014. It started to get covered widely. The first case I did at Christ Hospital was in 2020. Since then, we've done probably 250 or so. The way it's done is there is a generator, just like a pacemaker that's implanted, and it's implanted, and then there's a wire that's connected into the nerve that's located in the neck, and that's going to send a signal up to the tongue. What you see here on the right side, here, we'll show this video. This is an example of a patient who's had an implant and how he uses it and how it works. So I'll just go over this. You go home with a remote, and the remote's put on top of the generator, and you activate the device. The device sits here in your chest, and it's connected with a lead under the skin to the nerve that controls the tongue. The tongue is remember that big muscle in the back of the throat that needs to contract or be pushed forward so it opens up that airway. A lot of times I'll talk to my patients about the anatomy and thinking of it like a box. So if the tongue is in the front, that tongue can fall back and block that airway by falling back. But then there's other tissue on the sides that it can't control necessarily. So what we're trying to do is pull that tongue forward so it opens up that airway. This is a video showing how a patient without stimulation, what the back of the tongue looks like in the airway. I'm going to play it in a second, but I just want to explain what it is. Okay, this one, you'll see how it's not opening. This is an obstruction, basically. And then if you look here, this is while the device is working. So I'm going to play these. Okay, we'll play one at a time. How about that? So this is the back of the tongue showing that there's very small, narrow airway. Okay, play that one more time just so you can see it. This is the tongue, and that's the airway down here. Basically, there's nothing left. You can't see it because the tongue's all relaxed. We're looking from above. And then if you look at this video here, you'll see the contraction of the tongue opens that airway. So you can see the airway wide open down here. You see that big difference there. And this is what it looks like when you do a sleep study. So all of these are markers on a sleep study. So the airflow kind of it stops basically here, and then it starts and stops. These are those, gasping episodes. And then when the device gets turned on, you see that airflow is constant. Okay, there's no obstructions. And then you see the oxygen levels normalize. This is up and down, and then this kind of just stays normal. And kind of everything looks normal when the device is working. This has gone over, this had to go through rigorous studies and testing in order to get FDA approval. It got its FDA approval using a 5-year follow-up study where they followed over 100 patients who used the device and tracking their results. So you have basically, this is the score. So 29 is 30 is severe in terms of sleep apnea, and 5 is normal. Less than 5 is normal. So you had patients who went basically from severe down to almost normal here, 1 year, 3 year, and 5 years out. So that's the apnea hypopnea index. That's the number used to measure sleep apnea. Sleepiness scale, this is something you fill out on a questionnaire. And so these are also patients. 11 is very high. And you see that their symptoms have gotten better. So this is just a questionnaire asking about symptoms. And this persists over that 5-year period. So it's not something that patients do well and then get worse. This shows that even after 5 years, patients continue to do well. I don't have the slide here, but there's also part of the study. They show that majority of patients continue to use the therapy. Unlike CPAP, you have at least half of the patients will stop using it. Snoring, although it's not the primary objective of the device, they measured it and they show that there's a significant number of patients whose snoring just either went away or is very light. So the question they ask is bed partner to measure how bad the snoring is, and you have about an 88% reduction. I like this statistic because if you ask a patient in the end, hey, was it worth it? They got to give you the thumbs up or thumbs down. And when you ask them that, 94% of patients who in this study say they like this device. I guarantee you, if you ask that same question for any surgery, it's not going to be that high, whether it's back surgery or any kind of surgery or the tonsil surgery. That's you're never going to get that high number. So that's a very good number. And then this is just showing that even at their final visit after 5 years, on average, patients are using it for at least 5.5 hours. And again, it's been studied now extensively. There's over 250 articles now related to it. So it's a booming field. All sorts of data and studies on it. There have been over 70,000 implants now that have been implanted worldwide. And good news is insurances cover it. Every insurance that I know of now covers it. Medicare and commercial insurances, even the VA will do it. So just a word on qualification. Not everyone can have this therapy. You have to qualify for it. And so the things that you need to qualify are you have to have tried CPAP and failed it, meaning tried the CPAP and couldn't handle it, couldn't tolerate it. The other thing is you have to have a score on your sleep study that's at least moderate, and that number translates to 15. And I'm not going to go into the difference between central and obstructive, but central obstructive, we defined it. It's an obstruction in the airway. Central has to do with the communication of the brain to your muscles of breathing. So it can't be related to central. We're looking for obstructive apneas. So the other thing, and we do get caught up a lot on this one, is weight. So This is changing. This has changed in the last 4 years since I started doing it. BMI is a measure of how heavy you are compared to your height. So 35 is the cutoff for Medicare. Commercial insurances vary. Some are 32, some are 35, and some are 40. So it just kind of depends. So this is something that we have to look at. The last thing we do is we want to look at the airway. And this is a very important part of this procedure because you'll see somebody who meets these other criteria. But for me, I want to make sure a patient is going to do well. I don't want to do surgery on a patient and then they come back in 6 months and say it's not working. So for me as a surgeon, I want to do something that's going to help somebody. So I'm trying to pick patients, do the right thing for them, and make sure they're going to do well. So when we do what's called an airway exam. And so that's something that you would take a patient to an operating room suite, put them to sleep, and examine the airway while they're sleeping, because I'm trying to understand how things are collapsing. Are they collapsing front to back? Are they collapsing from the sides? Are they collapsing from all sides? So this to me makes a difference, and I will go over those things with patients when we get there. And lastly, just to understand how this therapy is used or how it's implemented is patients will see me or a sleep physician will be referred to me. We screen them for those criteria that we just said. We'll do the airway exam. If they qualify, we move on to the implant. After a month, that implant is activated. So there's a month gap between the implantation and the activation, because you want things to heal. After activation, you go through what's called like a titration. So CPAP, you're given the device at the right setting right away. Whereas with this device, you're starting off at a low setting and you're kind of building up over time because you're using the battery to create the contraction of the tongue so that it moves. You're not going to crank it up all the way right away. You start low and you just work your way up. And then so after about 4 to 6 months, when they're at a good place, you get what's called a fine-tuning sleep study to kind of prove that your sleep apnea has resolved. And then you kind of cruise control after that. That's all I got for the presentation. I'm happy to answer any questions. Yes.
I'm a cardiac nurse, and I was told that sleep apnea that's untreated enlarges your heart. Is that true?
100%. Because what are you doing? That heart is just working too hard and doesn't have the oxygen. So you're going to get cardiomyopathy. You're going to get hypertrophic cardiomyopathy. So 100%, right? You imagine trying to run a marathon without breathing. It's gonna take its toll on you. Yes, sir.
How long does that battery last that's inside you? And is it a pulse kind of electroshock therapy, or is it constant?
Good question. So the battery says 11 years. Okay, that's the expected lifespan of that. To change it, it's a very simple procedure. I haven't had the need to do it yet because it's only been around. I've only been doing it for 4 years, but that's a simple procedure to do. The pulses are coming so there's a sensing lead for when you do take a breath, and it synchronizes those pulses to your tongue with your breaths. So when you take a breath, it's sending that signal, opens up the airway. Yeah. And a lot of people will ask the question, what does it feel like? So the best way I explain to patients, from what I understand, is it's not a sensory nerve, it's a motor nerve. So we're doing all sorts of things while we're sleeping, right? Blinking and swallowing, and none of it we feel. So patients typically don't feel any of it. Now, if they crank up the remote too high, eventually you're going to feel a contraction. So at that point, patients, we tell them, you're at that right spot, come back down, and then we're going to get your sleep study. Yes.
What percentage of people that come to you are approved, to get this?
End up qualifying.
Right.
So I tend to get a lot of patients that are screened by the pulmonologist or sleep doctor. And so it's a fair question, but for me, I would say maybe 75% of patients that I see, I will qualify for them to move to the next step, which is the airway exam. The airway exam, it's about 80%. So, yes.
Is there any way an evil person with a computer can screw with somebody's Inspire device?
I don't think so. I've never heard of that. It's a closed system. It does use Bluetooth, but in the end, it's just a stimulation to the tongue. I've heard many funny stories from patients who will forget to turn it off when they wake up. So there's a timer that's set that it turns off after a certain number of hours. Well, if you wake up before, you have to turn it off manually. So patients will wake up, and to your question, they won't even remember that it's on, and they'll go to talk to somebody and they're not able to because their tongue is moving in a way that they're not controlling. So people will think they had a stroke, or they'll go to drink some water and it's just spilling all over the place. So in the end, it's just something you can just turn off, and it's just a tongue movement. Yes, sir.
How invasive is the surgery and what kind of anesthetic is applied?
So the surgery is general anesthesia. And in terms of invasiveness, you're making an incision, you're not cutting anything out. So to best answer that question, what's the recovery like, really, right? It's outpatient surgery. You have it done, you go home same day. There is always some recovery, some tenderness to the incision sites. That's usually gone within a few days. Most patients don't need the pain medication. The Tylenol and ibuprofen usually do it. Of course, everyone's different. So you'll have patients, some that have more pain, some have less, but it is an outpatient procedure. I usually tell them they can go back to work within a week.
Right.
So you said earlier in the presentation that first treatment option is weight loss.
Yeah.
Okay. It sounds like by the time they get to you, they've been probably tried that, it didn't work, maybe tried the CPAP, didn't work. How many people achieve, let's say, less, they get that magic number through weight loss?
So it's a low number. I don't know what it is, but weight loss is hard with those new drugs that are on the market, the GLP-1 agonists that people are using for weight loss. Obviously, it's made an impact. The thing to know though, is that if you drop 10% of your body weight, your sleep apnea score can go down as much as 40%. Wow. So 25 to 40% for just 10% body weight. So if you weigh 200 pounds and you lose 20 pounds, you can make a significant reduction in your sleep apnea. So some people go down to normal weight and they still have sleep apnea. That's an anatomic thing. That has to do with muscle tone, lack of muscle tone. So, and the risk factors for that are typically, the older we get, the less muscle tone we have. And so we do have patients like that. Yes.
What is the difference between the dental device and the Inspire?
So the dental device is a non-invasive thing. It's like a mouth guard, and it hooks onto your teeth and it pulls your jaw forward. So it's trying to do that same thing. It's trying to pull the tissue so that it opens up the airway. The Inspire is a surgical implant, and it works by stimulating the tongue, moves it forward, and opens up the airway. So totally different.
Who is like the best suited for which one?
So Inspire and upper airway stimulator is the surgeon. It's the ENT surgeon. That's what I offer. Oral appliance are usually given to you by like a dentist, a specialty dentist. So not all dentists do it.
Does insurance pay for that?
I don't know. I'm not sure. I think they do a portion at least, but I'm not sure. Somebody had a hand up. Yes, sir.
I was at my daughter's house one time and I fell asleep on the couch and I woke up and she said, "Dad, you got sleep apnea." I said, "No, I don't. I took a video."
Yeah.
Really? I'm laying there. She looks like I'm having a epileptic seizure or something.
Yeah.
I don't know.
Did you bring it to share with us?
No.
Yeah. So a lot of people will have sleep apnea and not know it until somebody tells them.
So is that what you look like when you eat up by looking at someone when they're sleeping that they've got it?
Because.
Well,
Yeah.
those are called witnessed apneas. And usually they're from somebody they tell, you look like you're dying, you look like you're choking, you look like you're drowning. And that's those, episodes that people will have. And so they don't necessarily know it until something happens. So, in the heart world, there's a lot of arrhythmias and they all get sent for sleep studies because they're undiagnosed until they have an arrhythmia. So a lot of people don't even know they have it until they have a problem as a consequence of it. They're not all symptomatic with sleepiness and whatnot.
Do you encourage people to sleep on their sides?
Sleeping on your side is ideal.
Okay.
From an airway standpoint, yes.
Remember, didn't they used to tape a tennis ball to your back?
That's the positional
That
therapy.
pillow you're talking about.
Yeah, exactly. Yes, sir.
Well, sleep apnea and snoring, what am I saying?
Sleep apnea and snoring, what is it?
Go hand in hand.
Okay.
So people with sleep apnea have an obstruction. People with snoring can have sleep apnea. It doesn't mean they have sleep apnea.
Mhm.
So if the tissue is vibrating, causing snoring, that's not apnea because air is moving. But when they stop moving air, that's called apnea. That's obstructive.
You
So,
can't snore when you're laying on your side though, can you?
oh yeah, you can.
Really?
You gotta take more
Stand
videos.
firm.
Yeah.
Everybody's got video something.
Yes.
So would you have to turn this off? Like, what if you get up in the middle of the night to get a drink of water?
So there's a feature called, there's a pause feature on it, and it'll just pause it for 10 minutes or so. And that's adjustable. This is an electronic device. There are a lot of settings that could be made. So there's a setting on there, it's a pause setting. So people get up to the bathroom, pause it, and it restarts at 10 minutes. Takes you longer to sleep, they adjust it, make it longer.
Is it easier to check, to make a adjustment accidentally?
No, it's not. You have to make an adjustment. You're talking, which adjustment are you talking about? Is there one you're referring to?
No, I'm not referring to a particular
Okay.
one.
Yeah, usually, no, that doesn't happen usually, like a mistake in a setting, no. Yes,
I got a question. So you hook up a little wire to the motor nerve,
correct.
okay. Does it get dislodged? I mean, that little hook,
Yeah.
that little nerve, I mean,
So
if you roll over from side to side over time, is it gonna unhook itself or?
it's very rare. It has happened, but it's very rare. Because the way it wraps, it's like this and then this. So it's very snug,
Oh, the wire goes.
the cuff. So
Well,
if
the
you
scar
think of the
tissue.
wire,
Okay,
as think of the nerve as this, there's two cuffs. It's like this, and then there's another one like this. So it's very snug. And then there's so much laxity in the wire. So any way you move, there was an issue at one point in the device that they changed something and then an adjustment was made and it never became an issue after that. So
Would the scar tissue help too?
eventually, yeah, I mean, there's going to be scar tissue around it and it won't move. You're right. Mhm.
have you ever had to change out something?
Yes, I've had to do it twice for that reason, because it moved and there was a point where something changed in the implant. The manufacturer changed something and then a bunch of surgeons around the country had this. And so everyone had to take a step back and then we adjusted the technique and it never happened again. So.
Was it covered under warranty?
That's a good battery life for 11 years.
Yeah,
Pacemakers don't
pacemakers
last
are
that
usually
long.
what, 5, 6, something?
I'm
like
sorry?
that? Pacemakers?
7.
7. Yeah. Because it's not used all the time. It's just used at night,
And
so
the
it's
loop
nighttime.
recorders are only 4.
Or it's pumping all the time, you hope.
Yeah.
Yeah.
Yes.
So are these somehow monitored? 'Cause I know it used to be with like, some heart monitors, the signals are sent to the doctor's office, or do you like, can you monitor this somehow?
So it is, it's all connected now to the cloud. The
Monitor?
data that's collected is usually things like how often did you use it? What setting was it at? You know, those things are collected, and when you go to your doctor, it's all reviewed with the doctor. Yeah, compliance,
Yeah.
right? Exactly. Yes, sir.
When using the CPAP, at least I wake up during the evening, during the night. What about, how long would that be as opposed to this implant in terms of waking up?
I'm sorry, I didn't understand the question.
He's waking up with his CPAP in the middle of the night.
Oh, yeah.
Would he have this? Would he have to wake up in the middle of the night?
CPAP's waking you up? Is that what?
I'm waking up with it on.
Okay. And you're asking if this will help with that?
Yeah.
So,
I mean, is this different? Because you said it's got settings and you wake up during the night.
are you saying you're waking up from CPAP to use the bathroom or something like that? Or is the CPAP itself waking you?
We use the CPAP, I rip it off, throw it on the
A
floor.
lot of people do that, yeah. Well, I mean, so the device itself shouldn't be waking you up. Now, if you're waking up to use the bathroom or something else like that, that's where the pause feature comes in, right? There's nothing that you're wearing, so there's no discomfort. You're not putting a mask on, there's no noise related to it. So essentially, all it's doing is a very simple thing. It's creating some movement in the tongue to open up that airway so that air can go down.
Okay, well, what I'm thinking of is, since we've been little, if we wake up in the middle of the night, what's it mean? We generally have to go to the bathroom.
Yep.
Yeah, that's true.
If you're waking up in the middle of the night and you're not having to go to the bathroom, what is it? And does this happen with the
We may need
machine?
a
So
settings
if-
redone.
If you're waking up, not having to go to the bathroom, that's probably something that you'll have to dig in deeper with, like the sleep doctor, to understand why are you waking up.
You might have to redo your settings, increase them.
Yeah, I mean, so certainly if this device starts off low and you're waking up because it's just not strong enough, then yeah, eventually that's what the hope is that the device, you use it, you go up on your settings so that it's relieving the obstruction. So if you're waking up because it's not strong enough, for sure, it's a setting thing. Any other questions? Yes, sir.
Odd question I come up with. Some people are deep sleepers, some people are light sleepers.
That's
Is
true.
there any correlation to apnea?
Is there any correlation from being a deep sleeper or light sleeper? So I will say, if you are an insomniac, for instance, this isn't for you. Because what that will do is it takes you an hour to fall asleep because your mind is running and you have a device that's going to turn on in 45 minutes. And you're saying, I got to fall asleep before this device turns on. It's going to create that anxiety and keep you up. So I actually ask every single patient how long it takes them to fall asleep, because if they're an insomniac, this is not going to help. This is not a good option for them. So being a deep sleeper probably helps, but being a light sleeper, you know, it just depends on kind of what kind of light sleeper you are.
Do you encourage melatonin?
Melatonin is just a sleep aid. I don't think it has any impact on this.
Doing
Or
the
not.
hospital
Now,
left and right now.
yeah, if you can't sleep, that's a different, right. So for people who have insomnia and unable to fall asleep, that's what it's for. Yes.
So I don't have a problem falling asleep.
Mhm,
My problem is staying asleep.
mhm.
That's a kid's problem.
Yeah,
And I go through ebbs, where periods of
Yeah.
time where but I've also had a brain injury. So
Mm,
that's why I haven't,
yeah.
I'm
You
concerned about putting a device in that might not be beneficial to me.
Yeah, so the brain injury shouldn't have any impact on it, but you also, the patients who come to me are usually seen and examined by the sleep specialist. So I consider myself the sleep surgeon, And the sleep physician is the sleep specialist, just like how you have a heart surgeon and a heart doctor. So the sleep specialist can help try to rule out other things like restless leg syndrome. That'll kind of wake you up at night. So that's kind of their area. And I lean on them to try to figure out those problems and to treat those and make sure that those are addressed and before they come see.
He's the last resort guy, yeah.
Yeah.
Yeah, because I know it doesn't affect the sleep apnea, but my brain injury does affect my sleep.
Okay, yeah. Yeah, I mean, if you haven't already, a sleep physician with a sleep study.
I've done
Yeah.
it too.
Yeah.
The first one was not long after my
Yeah.
brain injury.
Yeah.
And then I've done one recently and it was nowhere near as involved as the one right several years after.
The
brain
home
injury.
sleep study versus the in-lab study.
I went into a place to sleep, but the one that I did at the hospital at UIC, I mean, they glued
Yeah.
electrodes to my head and, you know, I even had to stay during the day and they figured
Yeah.
out my sleepiness during the day and everything. Oh, wow.
Yeah. And, you know, that goes back to sort of the sleep, what kind of sleep apnea is it? Is it obstructive? Is it central sleep apnea, mixed sleep
Do you
apnea?
have a machine? Well, with the second sleep study, they did give me a machine and I also suffered a concussion from a hit right here. And so the thing that goes on, it was very uncomfortable and the nasal one was just, there was no way.
Masks too, they're ones that just do the nose.
We tried
Yeah,
doing
okay.
multiple different masks.
Yeah.
All I did was wake up all night long,
Oh, no.
all night long.
Oh, no.
I woke up more than I did
Oh,
if
no.
I slept without it. So to me, it wasn't beneficial.
Yeah.
And I became non-compliant very quickly.
You're part of the 50%.
Yes. But if I'm waking up so
Yeah.
much that it's not helping me, it wasn't worth it for me.
There's no perfect solution. This is a solution. And again, it's not for everybody, but it's one solution.
It's the end of the road.
It's not the end of the road, but it's probably the best solution after. You know, if you want to get into it, a tracheostomy is the end of the road. But
Who wants that?
we don't do that very often.
What if you forget to turn this thing up? You walk around all day with it turned on?
So it does time out, it turns off, and it's preset 8 hours or 10 hours, and that can be adjusted. So you wake up and you don't turn it off, it'll turn off at the time where it's supposed to. So if you forget your remote or your remote falls down the balcony, it breaks, it'll turn off. Yes.
You were talking about that exam. Did you say under general anesthesia, how you're looking at the structure and all that? Do you have like a rotating bed or something that,
So what we do there is patients sleeping on their back because it's the most common position they'll obstruct, and they give them MAC anesthesia, so twilight anesthesia. It's not general, and they just put them. It's you won't remember it.
Or
Yes.
cardiac cath.
Like
You don't remember it's
yeah.
twilight sleep.
You don't remember it. It's propofol.
Drug.
And so they give that, they put them to sleep, patient obstructs or starts snoring, you know, just trying to understand what's going on in there while they're relaxed.
Pictures.
Yes, those are the stimulation of it's gone now, but
Yeah, you were playing with the wire.
yeah.
There's a comment
Yes.
online. I've lost a considerable amount of weight and I don't get the same results from my CPAP anymore. My score used to be 90% or better. Now it's 65% to 80%. Is my body getting too used to the CPAP and not taking advantage of the air? Can I reduce the air pressure as a solution to better scores, or do I need a whole new study?
Yeah, I would say to follow up with their sleep specialist, and they probably, if they lost a lot of weight, We talked about that 10% of losing their body weight will reduce their AHI, and they may be too strong now. So that's something that can be adjusted and it's probably changed, or anatomy side change probably doesn't need the same pressure. So they would need to follow up with their sleep doctor and maybe even get a new titration study or split study. Yes, sir.
Any problem if you get on an airplane with this?
Good question. That's, the device is like the pacemaker, so you get a medical card. Gets you through security. Another common question is MRI scans. And just like a pacemaker, it's approved. They typically follow a simple protocol, but you can get an MRI scan of anything.
The airplane is no problem.
No problem.
Just security.
Yes.
So if you see the death- if you see the death, rip it out.
Your card you get.
You don't have to carry CPAP,
That card don't
just the
always
remote.
work.
Huh?
That card don't always work.
Oh, it doesn't.
Yeah, I got a couple friends that had hip, I work for United. A
Uh-huh.
couple friends had hip replacement, had cards because it was triggering them off. Yeah, that's no good. We don't want that.
What do they do?
Wanda?
A lot.
You do, they go.
They wind
make
them?
it Go through the metal detector, they don't,
Okay.
cause I've got all sorts of cards for all sorts of, I've got all sorts, and they don't even, they just make you go through the metal.
I don't think anyone's missed a flight though.
Cause
I don't know,
they
I
don't care
haven't
about the
asked.
cards, so
Yeah.
That's horrible.
they don't believe you, so
Yeah.
they have to go through the metal detector.
Got a big scar, see?
So would they have reactable metal detector?
I've never had a patient, I've had patients go through it and not react.
Okay.
I've never had a patient tell me they have, but that's what the card is for, in case they get stopped, so.
Is there metal in there?
Yeah, it's
Oh,
metal,
oh,
it's,
okay.
and it's got a battery, so there is, metal in the generator.
Kind of like these car batteries that like to self-ignite, is it?
I've heard that, I don't think so.
11 years a good deal.
You're thinking about it, aren't you?
I don't have to see that. That's my old neighbor, so I came to say hi.
Yeah, it's good to see you. Any questions from the front?
How do you give the machine back?
How do you give the machine back?
Machine, yeah,
Get it or give it?
give it back.
I would just call your
Do you rent it
DME,
or own it?
Don't get rid of it.
You can donate it, I don't know.
sell it
I
on
think the
eBay.
insurance company pays for it.
Oh,
Right.
okay. There might be a number on
I'm sure the DME company will take it back.
I'm pretty tired of it.
Non-compliant. There's another for somebody like pick it up.
I get 2-3 hours and I'm ripping them off. That's 5 hours. Well, I'm so exhausted, then I get 7 hours, but they complained I was leaking all night.
Mhm. I do, yes. If there are no other questions, thank you guys for coming out.
Thank
Good to see
you.
you too. I'll leave my contact information at the desk out